relapse and how to retain the kind of corrections that we have achieved is a huge challenge. I mean, it is still very much of a gray area despite having so much research that has gone into how to retain, how to prevent relapse, and how often or how long do we have to do this, etc. So from that point of view, it is a super important chapter, but also from the point of view of examinations. And we will be looking at basically the theorems. It's going to be from a very structured around a very examination point of view about the theorems of retention, both the Riddle's theorem, the Rayleigh-William keys, and then we will be also looking at the different kinds of retainers, what causes relapse, and that will be basically the crux of today's lecture. So we'll be seeing a little bit about introduction, about the schools of thought, about the theorems, about the 6 keys to eliminate lower retention, the where does post-treatment relapse actually stem from, and retainers, the different types of retainers. So basically, to start off, I think we need to know what is relapse, what is retention, why retention, and how do we retain. These are the three main takeaway, large takeaway questions in today's class. It's going to be focused so much around these three questions. So to start with, what is retention and why do we need retention? So retention after orthodontic treatment by Moyers has been called as the holding of teeth following orthodontic treatment in the treated position for the period of time necessary for the maintenance of the result. That is, you finish your treatment, you finish your braces, you remove it, and basically what happens is to the new position that you have moved your teeth, you need reorganization of the entire periodontium. Until such reorganization kind of happens, you need to hold the teeth in these new positions for the maintenance of this result. The maintenance stems from the fact that you need remodeling of the entire periodontium. So the periodontium includes what? It includes your PDL fibers, your gingival fibers, your alveolar bone, all of it, right? Like, so all of it has to reorganize, and that contributes to the maintenance of the result. And until such a time where this whole reorganization happens, you need to maintain it. And that is what Moyers called it as retention. Riddle defined retention as the holding of teeth in ideal aesthetic and functional positions. Now, coming to what is relapse, what do you think is relapse? According to Moyers, again, loss of any correction achieved by orthodontic treatment is relapse. The Moyers definition, I would just like to point out, is the most easiest to remember. So if a question, which could be long essay, whatever, is asking about you to define retention and relapse, I would say just go ahead with the Moyers definition because it is short, crisp, and sweet. So according to Moyers, relapse is the loss of any correction achieved by orthodontic treatment, or how Resource said, it is a slip back to a former condition, especially after improvement or seeming improvement, right? And Riddle believed that the word relapse was too harsh, and he just preferred the term post-treatment adjustment for these changes. I mean, we're just playing around with words, but relapse is quite real, in my opinion. Relapse is quite, uh, how do we put it? It is quite disturbing, but you can somehow not predict it, but you have various factors that are kind of attributed to it. And we try our best, right? We try our best to kind of reduce the amount of relapse. So now let's go to a little bit of a historical perspective about the different schools of thought. The schools of retention is another question that has been asked from the point of view of short essays or just short answers. Now, before we go to that, we have a brief history about how retention is actually one of the most difficult problems in orthodontia. In fact, it is the problem, says Oppenheim. And I think I would kind of agree, because when a patient comes to you and you are explaining as an orthodontist, when I explain to my patients that, this is what it is, this requires your treatment plan to have probably first premolars extracted, it is going to be of this treatment duration, etc., etc. It is also the duty of either the clinician or the orthodontist to mention also the importance of retention. It is super important because the patient cannot be taking the retention phase any lightly. So, which is why Hans said that retention is the stepchild of orthodontia, because what happens with retention is that if they don't wear their retainers, everything goes for a toss. All your effort, all your time, the patient's effort. So it is important that you motivate the patients, reiterate that, retention is super important. So that is basically the history of it. These were just statements that were made, and these were statements made very early on uh, the development of orthodontics, because retaining was always hard, continues to be hard, right? Now, coming to the schools of retention, you have four main schools. You have the occlusion school, the apical base school, the mandibular incisor school, and the musculature school. So the occlusion school was given by Norman Kingsley, where they believed that Kingsley believed that if you got very good occlusion, if you were able to establish good occlusion of the teeth, that became the most potent factor in determining the stability of the new position. So good interdigitation, that is, if you have a good cusp-fossa relationship, a stable occlusion, he said that that was the best way to retain, and retention could be avoided as much as possible. So who gave the occlusion school? Somebody?
William King.
Kingsley. And the most potent factor he believed was occlusion. All right. Next, you have the apical base school. This was formulated around the writings of several authors, and the three main authors that it included was Alex Lundstrom, Macaulay, and Nance. They found that the apical base, the base at which the dentition lies, the apical base, was very important for correction and maintenance of a good occlusion. So it consisted of things like your intercanine width, intermolar width, and it is very important that they should be maintained originally. So basically, for this, I don't know how many of you would have observed while doing our PG. We have arch forms, right? So you have specific arch forms, and it is important. So we have a template. I think I'll send a picture probably of my own template on the group later, if someone could just remind me. So what we do is we keep these templates on the cast. We also see to that the arch form that was originally there is kind of maintained, because when you expand way beyond this intercanine width or the intermolar width, where you're expanding much beyond the apical base, you might get good results. You might solve the problem temporarily, but the relapse is going to be there, because apical base is very important to be maintained. This intercanine width, this intermolar width, they're important factors to be maintained. So it is important that you don't change them much. So this was given by Lundstrom, Macaulay, and Nance. And as an extension to this apical base school, I found this to be very useful. So basically, mandibular teeth upright on the basal bone was one of their takeaways. Arch length may be increased only to a limited extent, and avoid excessive labial or lingual tipping of your mandibular incisors. So if you're going to be doing any of these extreme tooth movements, it is going to cause a lot of relapse. So this was the tenet of the apical base school. So who gave the occlusion school? The
Kingsley.
first
Kingsley.
Kingsley. Who gave the apical base school? The three authors?
Excel, Armstrong, Macaulay, and
Nance. All right. Perfecto. Then we have the mandibular incisor school. This was given by Grieve and Tweed. Does Tweed ring a bell to anybody? The picture
Breach
on the
triangle,
right?
encephalometics,
Breach
Yes.
analysis.
breach triangle.
Yes. As an
Breach
extension of
diagnosis.
his, yes, very good. So as an extension of his cephalometric studies also, Tweed kind of believed that the mandibular incisors are always given. If you look at literature, if you look at orthodontists speaking about the lower incisor MP all the time, especially in terms of pre and post treatment, this is basically because of the mandibular incisor school, where they said that the incisor must be kept upright over the basal bone. So what was your IMPA angle? Does somebody remember? It's also there in the picture. Incisor mandibular plane angle. The average was, I know
87
which
degrees.
one.
87 degrees.
Yes. So general guideline is that it is tried to be maintained at 87 to 90. 90 is still very acceptable. Now, when you procline it too much in order to say decrease the overjet or that is the result, then that becomes again very unstable. And this was the tenet of the mandibular incisor school, that it could cause some periodontal problems. It could also lead to poor stability of the treated case, right? So this was the mandibular incisor school given by Grieve and Tweed, who suggested that the mandibular incisors must be kept upright over the basal bone. Last, you had the musculature school. This was given by Paul Rogers, who introduced the consideration of establishing a proper functional muscle balance. And if the occlusion is within the bounds, within the boundaries of this, muscle balance, then the stability of the results is also very, very good. Now, going back to that, uh, what are the, if you remember from introduction, I don't think we've taken a class on that, but I'm sure you must have all learned, what is the Jackson's triad? Anybody? The three
The structural balance,
Functional
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 efficiency
stability
and
and
stability,
aesthetics.
aesthetic
aesthetic.
harmony. So your structural balance, a lot of the musculature also comes in the structural balance, not just the occlusion, but also the soft tissues, including the musculature and the skeletal tissues. So if it is in good balance, then you also will be decreasing or minimizing the chances of relapse. And this was another school of retention. So now, before we go to the Riddle's theorems, can we quickly do the schools of uh, retention? Just say what are the schools, given by who, and the keyword of what was most important. We'll just quickly recap this and then go to the, because this is a lot of memory, this chapter basically. So what were the four schools?
Full of occlusion.
Yes.
Apical base school, mandibular
Yes.
incisor school, and musculature school.
Okay. Coming to the occlusion school, who gave it and what was important for retention there?
Kingsley gave
Kingsley
it,
and
and
occlusion is the
And
most
proper
important.
occlusion.
put
Perfect.
it.
Apical base school was given by who?
Axel
Three authors?
Armstrong, Macaulay, and Nance.
Yes. And what was important? To
Apical
maintain the
base,
apical base. So what
yes,
were the factors that were considered under this? The what width was considered?
Intercanine width.
Intercanine width and the intermolar width. Very good. What was who gave the mandibular incisor school?
Tweed.
And there are two people. Grieve
Grieve
and
and Tweed. Grieve
Greaves
and
and
Tweed.
Tweed. Yeah. And you have to keep the mandibular incisor upright over the basal.
Upright.
And musculature school was given by who?
Paul Rogers.
Rogers, Paul Rogers.
Perfect. Okay. After this, we came with uh, a very, very important, I think probably one of the most important questions from this chapter that has been asked several times is the theories or the theorems of retention. There are 10 theorems, and out of which the first nine were given by Riddle. The 10th one was added by Moyers to the same theorems of retention. So if somebody was to ask you the theorems of retention, the Riddle's theorem, uh, the first nine are given by Riddle and the 10th one is given by Moyers. And this is asked during your Viva often. Now let's look at each of this theorem. And it is also unfortunate that it has to be remembered in the exact same order. So I have still till date not found a great mnemonic to kind of remember this. I think it is just practice, probably do it a couple of times. The statements are fairly easy to remember, but it has to be remembered in the exact same order. Okay. So the first one is that the teeth that have been moved tend to return to their former positions. So basically what happens is that this is basically a cause of relapse. It could be very multifactorial. So any tooth that has been moved from its original position always has a tendency to return to their former positions, which is why we talk about relapse and the need for retention. So this was the first theorem of retention. Second one was actually, wait. Oh, so one minute. Okay, there has been the second one is actually elimination of the cause of malocclusion will prevent recurrence. So that is the second one. Third one is the malocclusion should be overcorrected as the safety factor. So what do we mean by overcorrection? Anybody? Why overcorrection? What do you think overcorrection will do?
So that if the treatment would relapse, it would
We
get
would
to the
still not
normal
be too
position.
severe, right? And this overcorrection as a concept was given by Roth. Roth also believed in the concept of overcorrection. So Roth is one of the pre-adjusted edgewise systems or a fixed orthodontic technique, and this was also kind of propagated a lot by the Roth's technique. So this is the third theorem actually. So the second one is the elimination of the cause of malocclusion will prevent recurrence according to Balaji, and we will stick with it. The fourth one is proper occlusion as a potent factor in holding teeth in their corrected positions. So when we say proper occlusion, what do you think is proper occlusion? See, how we are going to be doing these theorems is we'll be reading the statement. This is for you to remember verbatim later, but we'll actually try to understand these things. That's all we'll do. So let this be interactive. So when we say proper, okay, let's go to the elimination of cause of malocclusion. What do you see in this picture?
Thumb sucking.
Thumb
Thumb
sucking
sucking.
habit.
So basically any habit, right? So you know what happens because of thumb sucking or tongue thrusting. You will have a malocclusion, proclination, open bite, all of that. Now imagine if you're treating all this without actually addressing the cause. What do you think will happen? And you finish the case, you say tada, retainers, bye bye. And then what do you think will happen to the patient when you have not corrected the cause? What do you think
A
will happen?
relapse.
Mal
Basically, a
occlusion will persist. Relapse occur.
yes, perfect. So that's why they say elimination of the cause is important. So what how do you identify this cause? When do you identify this cause? During the course of treatment? What becomes important then? Your case
Case
history,
history.
Case history.
your diagnosis becomes very important. So you understand that the whole of orthodontics has a link. It has a sequence where every step is very important. I would say more than executing the treatment, diagnosis and treatment planning is very, very pivotal. That's why we have studied chapters like cephalometrics, model analysis, your skeletal maturity indicators, all the etiological factors of different kinds of malocclusion. So elimination of the cause is what will prevent recurrence. Then next we move on to the fourth one, which is proper occlusion. So what is proper occlusion according to you all? When we say proper occlusion, when Riddle is saying proper occlusion is a potent
Molar
factor.
key and
Class
canine.
1,
Yes.
class 1 occlusion.
Class one.
Maximum
Probably
intercustation.
having the
The
overjet
correct
and overbite
intercussion.
in proper positions.
Very good. So when we talk about proper occlusion, have you heard of the 6 keys?
Yes, sir. Yes,
So
sir.
one guideline is to achieve the 6 keys, but this is not ideally very fully all 6 keys to be achievable, but that could be a helpful guideline. But having said that, I heard somebody saying class one. Yes, a class one molar relationship is probably the most functionally efficient, but in a regular practice, remember, we also accept a good class 2 or a class 3 molar relationship as well, as long as it is stable. So when we say stable, what is a stable class 1, class 2, or class 3? We mean to say a good cusp fossa relationship and not a cusp to cusp kind of relationship. All right. So good occlusion, proper occlusion is a potent factor. And then the fifth one is that the bone and the adjacent tissues must be allowed adequate time to reorganize around the newly positioned teeth. So as we said, we will be studying this in the subsequent slides about how long or what kind of time a recovery is there for each of these periodontal tissues. So they must be allowed adequate time to reorganize. That is one. And then you have corrections that are carried out during periods of growth are less likely to relapse. Why do you think so? And where is growth? corrections carried out during growth more important?
In
Skeleton.
case of removable appliances,
Yes, growth modulation,
uh,
right? Your myofunctional appliances and all of that. So what is it doing? It is kind of intercepting extremely severe skeletal malocclusions to become very full-fledged malocclusions that get compensated later on and end up becoming surgical cases. But if you are able to catch them early and you are able to carry out these corrections during growth itself, they're less likely to relapse. So that is what it means. Then the farther the teeth have been moved, the lesser is the risk of relapse. What does this mean? So, say you have a particular tooth, you have moved it way beyond, uh, you know, or any particular, even a set of teeth. So, the distance, the farther they've been moved, they say that the lesser, because that much amount of reorganization and all of that, it sounds really logical. But they say he believed that it has a less chance of relapse. Then you have arch form, particularly in the mandibular arch, that cannot be permanently altered by appliance therapy. So this was given by Macaulay. What does this ring? What school of retention does this ring a bell with? Or apical base, right? So especially in the mandibular arch, your mandibular intercanine intermolar width are very uncompromising. So if you expand, see, if you expand way beyond this arch form, you will definitely have severe relapse. So they are fixed landmarks and you don't really manipulate with them much. Okay, and then of course the lower incisor must be placed upright over the basal bone.
so
Yes.
so the seventh one,
Mm-hmm.
uh, does that really happen or just that he believed it? Because
He believed it. I
relapse
mean,
will,
this sounded very logical, but it was just a belief that he had. But it is not necessarily so, because he came at a time, this was given way back, right? Like, so he believed this, but you see that each of these theorems can also be not entirely correct, but especially this one. I mean, it is a possibility, it is a logical possibility, but it is not entirely true, is how I would put it.
Sir, the seventh theory is more like a overcorrection, na? Right.
Kind of, right?
Okay.
It is a sense of overcorrection only. So that
okay,
even, but in overcorrection, the basic idea is that you overcorrect it so much that even if there is relapse, it is not too bad. It is still ideal, right? That is the this thing. But this, he's talking more about the distance of travel of the tooth in terms of its movement. It's logically sounding fine because so much it cannot relapse because of the stretch of the fibers and all of that, but not entirely true is how I would put it. Okay. Yeah. And who gave the 10th theorem? And the theorems do it only from Balaji. And you know how Balaji is given is that the first line has been given in quotes, right? And that is the statement. That is what is given below it about the theorem per se. Okay. And who gave the last theorem?
Moyers.
So this was subsequently added by Moyers. It was not the original part of Riddle's classification. And he believed that most treated malocclusions or many treated malocclusions required permanent retaining devices. So this we will come to what kind of cases require limited retention, moderate retention, permanent retention subsequently in the lecture. But this is what he believed. So these are the 10 theorems. Very important that you remember them. Go back to your Balaji, highlight the first line, and you will have to remember them exactly. And you can probably, if a question has been asked on this, you also give an explanation. Based, if you can remember the class and how we bounced off ideas as to try to understand what this means, you should be able to write it. Okay. Is this clear? Were there doubts with this? Can we proceed to the Raleigh Williams keys?
yes, sir.
Okay. So this is again another important question, Rayleigh-Williams keys. These are specific to the lower arch. These are keys to eliminate lower retention and achieve good lower arch stability. There are 6 theorems in this, or 6 keys in this. So the first one is that the incisal edge, basically, of the lower incisor should be placed on the AP line or 1 millimeter in front of it. So this ensures that the treatment result, whatever is there, is stable, and it creates optimum balance also in the lower third of the face. So AP is what? Point A to pogonion. So you connect this line, and the incisal edge should be either on this line, or it can be allowed up to 1 mm in front of it. This is the first one. The next one is lower incisor apices, that is the apex of these lower incisor crowns, should be spread distally to the crowns. So if you look at the root, this should be slightly more distal compared to the crown, and this he believed was appropriate, where the lower incisor roots were basically a little bit diverging. Okay. The third one was the apex of the lower cuspid. So if this is the apex somewhere here, this should again also be positioned distal to the crown. So earlier we spoke of the lower incisors. Now we are speaking about the lower cuspid. Same rule. Basically, even the root of this also should be slightly divergent. Now, if you look at the fourth key, the 4 incisors, that is your central and lateral incisors, should be in the same labiolingual plane. In this direction, they should be in the same labiolingual plane. And this means that they have to be centered over the basal bone and such that they are very well aligned. Okay, this is what it means. Then you have the fifth key, where the lower cuspid root apex must be positioned slightly buccal. That is, if you have this apex, this is to be slightly buccal to the crown apex. So that is one. And the last one is that the lower incisor should be slenderized as needed after the treatment. So if you have, these are the incisors, you do some amount of what is slenderization?
Reproximization of the stripping.
Proximal stripping. Proximal slicing, yes. So he said that the lower incisor should be slenderized as needed after treatment. So these are the 6 keys. So does anybody want to state these 6 keys? What was the first one? The APOG line. Yes, it has to be on the APOG line, or it is allowed to be 1 mm in front of it. Then what was the second one?
The roots of the lower incisor should be distally diverging.
Yes. What was the third one? This was an extension from the incisor to the canine. That was also, the apex was again positioned distal to the crown. What was the fourth one?
Root should be
lower
more less
incisor
buccal.
must be labiolingual.
Same labiolingual plane. Yes. The fifth one was in terms of the canine. Again, this being slightly buccal, the root apex being slightly buccal to the crown apex. And the last one is lower incisor should be slenderized as needed after treatment. Now, I don't know if I mentioned this in the class on methods of gaining space. Now, when the lower incisors are slenderized, basically to maintain the integrity of the arch or the stability of the mandibular arch after treatment, what is this proximal stripping, which basically say this proximal stripping will be done on opposite corners of the tooth, opposing sides of the tooth. Basically, what are you doing here? Why does it become stable when you do slenderization, especially lower incisors, not as a main method to gain space, but as a method to, increase stability? What is it doing? What is the proximal stripping doing to increase this kind of stability? What do you think is happening? We've discussed this, I think, before. I'm not sure, which is why I'm revisiting this concept. Anybody take a guess? It's okay.
Tight contacts.
Okay. What's happening with the tight contacts?
To avoid extraction.
No, but we are not creating massive amounts of space here. This is not a main method of gaining space here. This slenderization here is not to gain space, basically. It is just to increase stability, we are saying. So what is it doing to increase stability? We don't want so much space.
Eye contact will provide the retention and it will prevent the relapse of the treatment.
Interesting, but it's quite the opposite of it.
Normalizes the crowding.
No, anybody else? Interesting. So when you look at, when you've arranged your teeth also in preclinical prosto second year, when you go back to second year, if you notice when you arrange in good alignment these incisors, how do you think the contact
It
points are?
kind of reshaping the arc. So that's helping in stabilization. Is that
This
is
is an
correct?
answer getting there, but yeah, close enough. But so yeah, now when you arrange, when you see a well-aligned mandibular, when you see well-aligned lower teeth, well, how are the contact points between the lower incisors? Is it a broad contact point or is it like a small focused contact point?
Small focus one.
Yes. So basically, what happens when it's a small focused contact point, especially after treatment, and you remove the braces, is that this small focus, very tiny contact point can be an area, can be a point where the teeth actually slip and relapse. So the whole point of proximal reduction for increasing stability is basically increasing the surface area of this contact point to a larger contact area. So when you make it from a point to an area, it remains more stable in contact with each other. So this was the idea of slenderizing in order to increase stability. Now, when you did the same proximal reduction on the opposing sides, like in opposite direction. So if you reduce here, right, you're also reducing here on the opposite side. This procedure is called as keystoning. It's something that can be asked in your viva, and it's specific to doing proximal reduction in the lower arch on the opposing ends, where you kind of increase the surface area of a contact point into a broader contact area. What is it called as? Keystoning. It is called keystoning. Key, your lock and key, and stoning. It's called keystoning. Is this clear? Is this concept clear?
Yes, sir.
Okay. So we've come to finish with the Rayleigh-Williams keys. Now we're talking about what is actually happening for relapse to occur, like individual tooth positions and all of that. So basically, you just hear to what I'm saying now. You always have your teeth that are held in position are going to be subject to a lot of pressure, right? Between your tongue, lip, your cheek pressure, your pressure from the gingival fibers, etc. Now, these are small but prolonged imbalances. And if you continuously had these imbalances, teeth would keep moving. But the teeth are not actually moving like that all the time. And that kind of tooth movement is resisted by a concept known as active stabilization. Very important. What is active stabilization? It helps the teeth not move in order to pressures from your tongue, lip, cheek, or pressures from your gingival fibers, but the teeth are actually still being held in place. And that resistance is called as active stabilization. And this is because of the pedial metabolism. All right. So it's an important concept from your NEET point of view as well as for your viva. So active stabilization is the resistance for the tooth to move to all these pressures, because you have pressures like up to 5 gram from the lip, more than 5 gram from the tongue, and in the lower arch and the upper arch. So many pressures acting on the teeth, but the teeth are not actually moving, even though they are small imbalances but prolonged. And this is because of active stabilization due to pedial ligament metabolism. All right. So yeah, this is about that. Now, what happens during your treatment, basically? How do these fibers get reorganized? So whenever you're moving a tooth orthodontically, there is disruption of the PDL. Do we agree on this? Going back to biology of tooth movement, you have pressure side, tension side, your fibers, the PDL space is kind of enlarged, widened, and all of that. So there is a disruption of the PDL. There is basically after treatment, there is reduced active stabilization, because what is happening? Because the PDL being destroyed, normally without any orthodontics, the tooth is being held in position metabolism by active stabilization. But when it is orthodontically treated and the case is finished, your PDL fibers are kind of yet to reorganize. There's disruption. Because of this disruption, there is elimination or reduced active stabilization. So till these things reorganize, the teeth will be unstable in the face of occlusal and soft tissue pressures, which is why it is important that patients need retainers for at least a few months till all this reorganization occurs. Is this concept clear?
Yes.
Okay. Now, as an extension to this, there is reorganization of your gingival fibers, there's reorganization of your periodontal ligament, PDL fibers, and all of that. But remember, generally, your gingival fibers are not as easily reorganized as the PDL fibers. The PDL fibers, especially in the middle and apical regions, have a fairly short retention period or a fairly short reorganization period. But whatever strain is happening in the gingival fibers can persist for even after a retention period of about 232 days, which is why we give months of retention, right? So the principal fibers of the PDL reorganize in easily about 4 weeks, but your gingival fibers take much, much longer. So when you remove braces of a patient, relapse in the first week of orthodontic treatment is usually because of the PDL fibers. But the PDL fibers get reorganized in very quickly, at least in about 4 weeks. But the gingival fibers have a much longer reorganization time of about 232 days, which is why longer periods like relapse that occurs after quite some time is probably because of the relapse due to gingival fiber. Okay. Now, as an extension to this, this probably is not super important for you from your exam point of view, but it greatly adds to your answer if you can write this. But this is super important from a NEET point of view. So this is a timetable for tissue recovery. So the periodontium has not just PDL, it's also the gingival fibers, supracrustal fibers, your alveolar bone, and all of that. So I would say write down this table probably quickly. The PDL ligament as a whole takes about 3 to 4 months for complete recovery and reorganization. Gingival collagen fiber network takes about 4 to 6 months. The supracrestal fibers, which are gingival fibers, take more than 232 days, and the alveolar bone takes around 1 year. So this kind of deviation that we are talking about, that is relapse, is also more after correction of certain teeth like rotated teeth. So rotated teeth usually relapse because of your transeptal fibers. Okay, it is more with that. Even with space closure, like rapid space closure, there is a tendency for it to relapse because you have an epithelial compression or an invagination over there. And these kind of deviations or relapse is also more common on certain teeth, like your lower lateral incisors, canines, and second premolars, which tend to migrate towards their original position much more frequently. Okay, so this is the timetable for tissue recovery. How long does the PDL ligament as a whole take to reorganize? Just read it out loudly so that it probably sits in your heads.
3 to 4 months.
3 to 4 months.
Gingival collagen fiber,
4 to 6
4 to
months.
6 months.
your supracrystal fibers take more than 232 days, and alveolar bone.
Around 1 year.
So does it make sense now to why you probably advise patients that you need up to 1 year of wearing retainers?
Yes, sir.
So if somebody is to ask you, say a friend who doesn't know about dentistry, why 1 year of retention? It is because of this. It takes so much time for that new position of the tooth to be accommodated in terms of reorganization of the periodontium. Okay. Now, what is happening with relapse? Where is this post treatment relapse happening from? Where is it coming from? This has multiple reasons. It is not because of one particular thing. One is the periodontal and gingival tissues, as we just saw. If you don't give adequate time, for it to kind of reorganize and rearrange, it will kind of relapse. That is already said. Oral and orofacial soft tissues. What do you think will happen? How orofacial soft tissues can be a reason for relapse? What kind of orofacial soft tissues are we talking about contributing to relapse? Think quite laterally.
Lip,
Lip.
Lips,
So what are
tongue,
all these
cheek,
things? Lip, tongue,
muscle,
cheek, muscle. They're all muscle forces. So muscular imbalance in terms of these orofacial soft tissues can lead to relapse. Now, occlusion. What are we talking about in terms of occlusion? The good keys of occlusion kind of being maintained. Also, the centric occlusion that is being considered, and good intercuspation if all that is not there. And what are we talking about? Relapse due to post-treatment facial growth. What is this?
Sir, in a growing patient, if we do a treatment, then after that also it can grow.
Yes, there could be abnormal growth, right? So what becomes important in such cases then to prevent this kind of this thing? A good growth prediction would help. Okay. To know that, you've kind of, how much growth you're anticipating, how much time will it take for this growth to get complete, and all of that. Of course, sometimes despite all those efforts, if there is any abnormal growth, is really beyond the control of us. But at least taking these precautionary measures and a good diagnosis would kind of help. So causes of relapse are basically this. Also, we can also identify other causes like failure to eliminate the original cause. Some people believe that the erupting third molars later would also cause, that pressure that is exerted by those lower third molars was believed to cause late anterior crowding and relapse. Also, bone adaptation, like, if you're not giving, how much time does it take for the alveolar bone to adapt?
Around 1 year.
Around
Yeah,
1 year.
1 year.
Yeah. So the bony trabeculae are also, when you do treatment, usually they're arranged perpendicular to the long axis of the teeth. But after the treatment or during the orthodontic treatment, they get aligned parallel to the direction of the force, if you remember in those biology of tooth movement. So during the retention phase, they now revert back to the original perpendicular position. So you need to give time for all of this to happen. So that is with regard to your bone adaptation. So all of this, if not taken care of or not kept under consideration, they can lead to relapse. So these are few causes of why relapse can occur. Now, yes,
So,
I can't hear. I think you should go one after the other. Yeah. Please ask.
Sir, in cases say we have a rotated molar teeth and
Mhm.
we do fibrotomy of the supraalveolar gingival fibers, will it lead to better stability and will it lead to less period of wearing retainers?
Yes. So basically, a periscission, the procedure you're talking about is periscission or circumferential supracrestal fibrotomy. So because the supracrestal fibers, transeptal fibers are believed to cause rotational relapse, they believe that eliminating or, giving an incision and periscission of these fibers kind of add to the stability of these derotated teeth. Having said that, just doing a CSF or just doing the periscission is not going to be the complete option. It also has to be in tandem with giving a good retainer. It has to be both. Okay.
Sir, won't it affect the soft tissue around the rotated tooth?
No, it's very carefully done as to what it depends on how the blade is going inside. So when we are doing surgical orthodontics, we will talk about how this periscission is done. So you're taking care such that you're only probably removing these transeptal fibers. It's not too deep an incision like a flap or anything where there can be a lot more damage or it's more invasive in that sense. So not really. No.
Okay, sir, thank you.
Yes. So now coming.
in the so the fourth category that we were studying,
Mhm,
post-treatment facial growth. So we are
mhm.
treating the individual keeping in mind that growth will occur, right? So relapse in this particular category, I mean, is that even practical?
Yeah, see, of course, you're keeping in mind that growth will occur, but we are talking more about changes in, say, you have a patient, to give an example, say you have a patient who's a growing class 3, right? Like, why do class 3s grow much more? Because the mandible usually grows much at a much longer rate than the maxilla. So say the patient came to you at say around 14 years and you saw that they were a developing class 3, you corrected it, everything is done by 15, say by 16 years, you have finished with the treatment, but there is still some amount of growth left. So you have to, if there is a huge catch up growth later, then there can be very bad relapse. So what helps here is you have cephalometric methods and methods where you can kind of predict how much growth, or you can take serial cephalograms which kind of help tell you how much growth is predicted, to kind of avoid this tendency. Of course it can happen, not in cases where there is a very minor, like say you're treating crowding or something like that, but in cases where there is a skeletal malocclusion like a growing class 2 or a growing class 3, can always aggravate the problem even post treatment. It can happen. Okay, skeletal malocclusions with anteroposterior or vertical. Yeah. Now, next, coming to your retainers, you have removable retainers, you have fixed retainers. We classify them like that. So removable retainers, you probably are giving it in your final years or sometimes even in internship, all your Hollies retainers, Beggs retainers, all of that. So these should be allowed. So the ideal requisites is that they should be able enough to allow functional occlusion. They should be good, sturdy enough to withstand long-term use, convenient for the orthodontist to provide, and it should also be comfortable. So you have different designs. Let's quickly go through that. I'm sure you would have seen a Hollies appliance. So a Hollies appliance is basically an acrylic plate. You have a labial bow and you have an Adams clasp. The original type had just the labial bow, but the clasp came in later as giving more retention. So you have a 0.020 or 0.036 stainless steel inch stainless steel wire, and you give a Hollies appliance. You can give Hollies appliance with a long labial bow, short labial bow, fitted labial bow, whatever. The design of it being an active removable appliance in terms of having a labial bow and an Adams clasp is the Hollies appliance. So you have various modifications. The original design, like I just said, had no clasp. You can give a ball end clasp, Adams clasp, C clasp, whatever. Sometimes you can even give a clear outer bow, which is more tight than a metal wire and also aesthetic. So this is the Hollies appliance. Next, you go to the circumferential retainer. This is also known as the Beggs retainer. All right. The Beggs retainer is basically one wire that goes from the second molar to the second molar. So this became a little advantageous compared to the Hollies. Why do you think it's a little more advantageous than your Hollies appliance? Look at the Hollies here. You know that it has a labial bow. Now, in comparison to that, why do you think this might be slightly advantageous?
No
Covering the
interference
whole
with
arc.
occlusion.
Pardon?
No interference with occlusion.
Yeah, that is one. And there is no crossover wire. If you know, with the labial bow, you have a crossover wire, right? Between the canine premolar and all of that. So there can, if an improperly done bow can actually cause the space to open up, and this kind of eliminated that, the circumferential retainer or the Beggs retainer. Okay. It also gave good retention, and it included the second molars also, so it kind of also maintained the arch width changes and in the transverse direction. So these were the advantages. Then you also had Beggs retainer, the same circumferential retainers with something known as keeper wires. If you see here, a wire that's going between the lateral incisor and the canine. They just added it to basically enhance the stability, especially when there were pontics and things like that. So here you have a pontic. You also, with the appliance, you have a replacement. So they help, these keeper wires kind of help. It was only a modification. Okay. Now going to the next one. You have another kind of retainer called as the wraparound retainers. So with the wraparound retainers, it's basically a plastic bar here that goes along the lingual and the labial surfaces. So if you see, you have an acrylic plastic bar that goes, it wraps basically around and holds the teeth firmly in position. And canine to canine was a clip-on retainer. It was like a clip, basically spring. It's also called as a spring aligner or a clip-on retainer, where both the labial and the lingual wire segments are embedded in a strip of clear acrylic, where they found that it held the teeth firmly in position. All right. So what are the retainers we've seen so far? We saw the hollies, we saw the begs or the circumferential retainer, we saw the clip-on or the spring retainer or the wraparound retainer. Now the variants of the wraparound retainer, it can be from 4 to 4, premolar to premolar, or canine to canine. All right. It can be given both in the upper and the lower arch. You have something known as the rickets retainer. How does this look different? Anybody? Just look at the design.
C class only thing.
It's not a C clasp. Is it a C clasp? It looks like a C class, but basically the same loop has been extended to form a kind of a C class, but it is actually wire bending there that curves distally around the canine, and it kind of forms like a canine loop because these teeth have been moved, especially in cases of extraction. So the wire is not going between here, and this also kind of stabilizes that canine. Okay, so this was the rickets retainer. So basically this labial wire has been recontoured to form like a distal canine loop of sorts, and it helps especially in extraction cases. Now, what are the drawbacks of removable appliance? What is the main drawback that you can think of?
Patient compliance.
Of course, always very good. That is like the biggest problem. They don't wear it, or they are poorly motivated to do so. So what do you think can help? Follow-up visits can help. Don't just shoo the patient away because the treatment is over. At least motivate them to come maybe once in 3 months or once in 4 months. Motivate them, check if that accountability from the patient is also there. That is one thing. And inability to maintain precise incisor alignment has been seen. And some rebound, especially if you have these crossover wires and even the labial wires. If you give a very active labial bow, they can be rebound, especially in the lateral incisor. And sometimes return of mandibular incisor rotations, which is why in the mandibular arch, particularly, we also prefer a fixed retainer. Okay. Now you also have something called as the positioners. Positioners are again clear appliances, tooth positioners that help. It was given by Kessling. It was called as the Kessling tooth positioner. Basically thermoplastic rubber-like material, which went interocclusally, if you see, between the upper and the lower, and a small amount of gingiva it covered. So it did not need any active activation or something. It helped in bringing about minor tooth movements, but this also acted as a good retainer. One major advantage is that it maintains the occlusal relationship as well as the intra-arch tooth position. But disadvantage was that, what could be the disadvantage with this? When the patient is biting, wearing this and biting into this? What could be a disadvantage?
Difficulty in speech.
Yes, difficulty in speech became a big problem. They also said TMJ problems were there, but not too much, but mainly difficulty in speech. Because you're biting onto something, so speech obviously becomes a cause of concern. Then you had your invisible retainer. These were also eventually called as the Essex retainer. It was originally kind of brought about by Robert Ponitz of Ann Arbor at the University of Michigan. So this was formed out of biocryl. It was a thin sheet of biocryl that you thermoform or vacuum form over using suction and pressure over the casts. So the purposes was that you could also bring about long-term retention. It could be a transitional retainer after doing minor tooth movements. All right. So small tooth movements could be done, and then you shifted it to a more permanent retainer, like an invisible S6 retainer. So an S6 retainer specifically was introduced by John Sheridan. This is quite popular even in practice. We do prefer, especially for patients who prefer good aesthetics and things like that. So the S6 retainer is again very useful in such patients. It is again a plastic removable retainer that snaps around all the teeth. It's basically like an aligner. It's invisible. It can be used as a retention appliance, also as a tooth positioner. More than a tooth positioner, it can help in moving the teeth. Basically works like your Invisalign or something. Inexpensive, not very expensive. It has very less bulk. It's much more convenient to wear, more aesthetic. It doesn't require adjustments and all of that. So it cannot do any great tooth movements. If it does do tooth movements, it has to be kind of, you should bring about a subsequent, aligner or S6 retainer after that tooth movement has been done. So this is about the S6. You have two kinds of S6. You have a canine to canine, and you also have the full arch S6 appliance. This is the canine to canine, just to hold the buccal section of the tooth. And it is worn, such that it covers the it is basically involving the stability of 1/3 of the teeth. Next, the last part. I'm sorry, I'm rushing because it became a little overboard with time. If that's okay, we'll just finish it off. Next is your bonded fixed retainers. These are your permanent retainers, as you call it. These are bonded retainers, where when it is generally used when you have intra-arch instability, usually in the mandibular arch, where prolonged retention is required. Okay, so you could give it from 3 to 3, which was very common. You could also give it in terms of extraction cases. You could give it even from premolar to premolar. So in cases of midline diastemas, you have different kinds of fixed retainers. You also give this to closed diastema. I mean, in cases where you have closed diastemas, spacing of anterior teeth, if they have like post-orthodontic, periodontal problems, you give these retainers. Accidental loss of maxillary incisors, also you can give these retainers. Even in, you remember if we did single incisor extractions, especially in the lower arch, even to prevent those kind of space openings, reopenings, you can give these fixed rotated. We spoke about rotated tooth. Apart from the CSF, you also prefer a fixed retainer or a bonded retainer in such rotated teeth, especially incisors. If they were impacted, crowded teeth or impacted canines that have been brought into occlusion, again, becomes an indication for these bonded retainers. Now you have basically you have retainer wires that can be contoured around the tooth, but you also have prefabricated retainers with a mesh pad, preformed ones, which help achieve a good fit. So if you see, you'll get something like a kit like this, where you have a retainer wire with the mesh pad. You just have to bond the mesh pads and contour this thing. So half your job is done in terms of it being easier and it also giving a good fit. So these are like preformed available, but obviously going to be expensive. So usually for your retainers, we prefer giving coaxial wires, or coaxial wires are basically multi-stranded, or coaxial wires are where you have 2-3 stainless steel strands or whichever material is used that are wound around each other to give a coaxial arrangement. Okay, so coaxial wires are very commonly preferred as retainer wires. Also, you have preformed ones like this. You also have something known as the cross-lingual retainer, given by cross, where you have mesh pads on each of the tooth. Bondable mesh pads connected by wire to each of the tooth. This is adapted to the lingual surface. This helps in stabilizing very mobile upper and lower anterior teeth. So particularly useful if they have periodontally compromised dentition. Then coming to this, what does this retainer look like? Is it aesthetic, non-aesthetic? It's a resin, fiberglass bonded this thing. It is usually comes under the brand name of Fiberbond. It is practically invisible. So these fiberglass strips would be available like this. You soak this in composite, and after you acid etch the enamel, you put these soaked composite fiberglass strips and bond it to that. So what is the advantage of doing this? It reduces the bulk of the retainer. It also creates a rigid splint, which kind of limits physiological tooth movement because we are constantly, the teeth are moving. It's greater, it has diurnal patterns and all of that. That could be limiting or it could be a shortcoming. So lastly, coming to the last part of this lecture, you also have adjunctive procedures to kind of enhance the stability and decrease the chance of retention, chance of relapse. So under that, you have a procedure called as the circumferential supracrestal fibrotomy, also known as the CSF procedure or periscission, also named after the author. It's also called as the Edwards procedure. Then, in cases where there is severe gingival inflammation, or you kind of need gingival, gingivectomy or gingivoplasty, these can be a cause of relapse. So, identifying those cases and doing a gingivoplasty or gingivectomy will actually be an adjunctive procedure to enhance the stability. Frenectomy in cases of midline diastema and interproximal stripping. What was that called to enhance the stability? What was that particular term to it?
Keystone.
Keystoning.
Keystoning.
Okay, so this is the end of this lecture. It is also important to remember, I'll finish with this part. I've not put it as a slide, but just listen to me and go back to Balaji and read, and then we can take doubts. You have types of retention, right? It becomes important to identify the types of retention in terms of whether you're giving it for some time or a moderate amount of time, limited retention, moderate retention, and permanent retention. So limited retention, the cases that come under limited retention are cases of corrected anterior crossbite or posterior crossbite that have good occlusion and axial inclination. Any case treated with serial extraction, blocked out teeth that you have brought into the arch form also require limited retention. Now, cases that require moderate retention is class 1 non-extraction cases with spacing proclination, or class 2 div 1 or div 2 cases treated by extraction, corrected deep bites, or early correction of rotated teeth before the root formation has occurred, or corrected class 2 div 2 malocclusions are all cases for moderate retention. Now, where do you require permanent retention or long-term retention? What cases do you think?
Rotated tooth.
Rotated teeth, very good. Diastemas, spacings, abnormal musculature, periodontally compromised cases. Also in a transverse direction, where do you think? Where will you have transverse collapse?
Crowding.
Crowding also requires permanent retention, yes, but transverse relapse, where do you think is arch expansion cases and expanded arches in cleft lip and palate patients? Because cleft lip and palate patients also have that ripple effect of, that uh, contraction where there can be transverse collapse of the arch, and certain deep bite cases also. Okay, so this is about the different areas that was limited retention, moderate retention, and long-term or permanent retention. So I will stop screen sharing. We've come to the end of this lecture. So these are the areas that you will be questioned upon: the theorems, the keys, the causes for relapse, how much reorganization, and the kind of appliances also that are given. Are there any doubts with this lecture? Was it okay? Are you fine with the concepts? Have you understood it? We can take questions if anything. Otherwise, you can come back or WhatsApp me or ask Dr. Shraddha, whatever.
Sir,
Yes. Yes, Labani.
sir, if you could just explain, repeat once more the concept of keystoning.
Okay. So with keystoning, basically, I told you that we do proximal reduction or IPR for stability. You're clear with that, right? So
Yes,
with
sir.
keystoning, what happens is that you are creating a contact point is being widened to a contact area so that they remain in good alignment. That is one thing. But how do you go about the proximal reduction is that you do it on opposite sides. That is, if you're doing it on one side of the tooth, it is done on the opposite side. I will share a picture probably of keystoning on the group if that helps to kind of understand that better. Will that work? So that you will understand what am I talking about in terms of direction. When I'm saying opposite sides, I don't know if you're able to capture that in terms of me saying it. I'll probably send a picture, just send me a reminder. I tend to forget. But if you send me a reminder, I'll just post a picture of what a keystoning procedure looks like in terms of the direction of the IPR, where it is actually doing that contact point, contact area thing. Okay.
Okay, so thank you.
Yeah.
So can you please provide a picturized classification of all the retainers that we have seen? Like previously also you have also provided one of the PDFs.
For the
Showing
expansion
the-
appliances, something
Yes,
similar to
yes,
that.
yes. Yes, sir.
Okay,
Actually, it's
I'll
very
do that.
helpful to.
Yeah,
Thank you,
okay,
sir.
I'll do that. I'll give me a day's time. I'll just get back. Again, please, my number would be there. Just send me a reminder if I don't do it. Okay.
Thank you.
Don't hesitate. Yes. Keystoning I'll put up now because I have something for keystoning. But anything else that came up for you all?
Sir, I had a doubt in management of open bite.
Okay.
Sir, in for managing open bite, we do give in anterior open bite cases we do give posterior bite planes, right?
Yes. Yes.
Why for supra eruption of anterior teeth, like basic that is the function of bite planes. We want to supra erupt the teeth, right? Why
Mm.
don't the teeth supra erupt on its own? Like why do we need an appliance for it to supra erupt? Anyways, there is open bite, there is space, there is no contact. Why doesn't it supra erupt on its own?
You don't have to always give it, but with open bites, the reason of giving it is either that molar extrusion or intrusion can happen either because of a persistent habit that you've not corrected, or more than that, habit though should be corrected because it's the elimination of cause. But probably if they have a continued eruption of posteriors, or if they're skeletally prone for more vertical growth tendencies, giving this kind of an intrusive effect or something like that would help keep that under check. So in such cases of open bite, sometimes we also retain them with a high pull headgear or something also with a bite block. So your functional appliances, sometimes your appliances with your headgear could also be given to retain that vertical growth to be under check. So which is why you probably prefer in cases where you're anticipating that kind of a vertical growth. Otherwise, not really required, I would say.
Sir, but my question was basically why don't teeth supra erupt on its own? Like if there is any other place in the arch
Because
where
the supraeruption is going to cause some kind of an occlusal disturbance, right? Like that would cause a malocclusion. So we would have to correct the supraeruption if that is particularly causing an open bite. Why would we keep it?
but we do need supra eruption of anterior, sir. With like I guess that is what we are. Apart from intrusion of the teeth, we are trying to achieve extrusion of some portion of the teeth too with the bite planes.
That is
So
with the posterior teeth. See, with deep bite and open bite, they're opposites. With deep bites, you're trying to intrude the teeth, anterior teeth. You're also extruding the posterior teeth, depending on what nature of deep bite it is. If it is going to be a true deep bite, false deep bite, whatever. So it helps in kind of understanding what deep bite or open bite, what is the cause of it. So you can't say supraeruption is always needed or not needed, right? Like with an open bite, you sometimes can close with the help of supraeruption or extrusion of anteriors, but that is not always done. That is done in a case of dentoalveolar open bite. But if it is skeletal, we don't approach the case itself that way. So you have to maintain that intrusion of, say, posteriors or prevent over extrusion of anteriors because it can also ruin the aesthetics of the face.
okay, sir, got it. Thank you.
Yeah, it's basically, Sakshi, it is to identify what kind of, where the, like during your diagnosis, where it is coming from, like what is causing that deep bite or open bite. that would be a good indicator as to how your retention. So remember, I think many have left, but it is also important during your diagnosis and treatment planning to also forecast what kind of retention you will be applying at the end of the treatment. And this would depend on a lot of factors. Like, this was a very good example. So it was a good question in terms of whether, how would you treat, how would you give a retainer for such a case. So you have to forecast it way before, but at the diagnosis and treatment planning stage. So it would depend on what kind of an open bite it is. So it is useful to identify that nature of the open bite and then go about thinking what kind of retainer you would give. Okay.
Okay, sir. Thank you so much.
Any other doubts?
Sir, during my Viva, a
Uh-huh.
question was asked that what is the 11th theorem of retention? I couldn't find it anywhere actually.
As far as
11th
I
theorem.
know, there is no popular 11th theorem. Even I am not really aware. I'm sorry, because normally it's been just the 10 theorems and this. But if there is one, if you could just give me some time, I will look it up, and then if there is something, I will get back to you. Is that okay? Because I am not aware
Yes,
of
sir.
11th theorem, honestly. So
Yes, sir. Okay, sir.
yeah, I'll get back to you if there is something. I'll search, find out an answer for you, and I'll get back to you.
Okay, sir.
Yes. Okay, Kushal.